Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest in North Carolina. Brian, how are you?
Hey, great, Peter.
Well, before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, so today we have an episode on capitellar osteochondral defects. This is an area of continued controversy where similar cases can be managed very differently by different surgeons. Some advocate arthroscopic management, others advocate autograft, others advocate allograft. And to discuss, we've invited two nationally renowned experts. First, from Kaiser in Los Angeles, we have Dr. Raffy Mirzayan. Raffy, welcome to the podcast.
Hi, guys. It's an honor to be here.
And next, from V2 in New Orleans, we have Dr. Buddy Savoie. Buddy, welcome to the podcast.
Thank you, Peter. Thank you, Brian. It's an honor to be here.
Okay, so I want to start at the beginning. And what I want to start with is etiology. So maybe starting with you, Buddy, what causes this problem? Is this traumatic? Is it AVN? Is it an autoinflammatory problem? Is this one disease or several diseases? When you think about a capitellar OCD, what do you think this comes from?
I think it's a variety of causes. Over the 40 years I've been doing this, it's been thought to be repetitive injury, a variety of different things. And I think at some point, I believe there's a genetic predisposition to getting it. I think it's a disruption of the vascular supply. I think there's some autoimmune factors involved in it. And then there has to be a stress to make it symptomatic. And at that point, then you start wondering how best to manage it. There's a lot of different ways to do it. Raffy clearly is a pioneer in some of the newer techniques.
Raffy, what would you add to that? I mean, do you think that, like, when I hear that, it sounds like it's both traumatic and vascular and genetic at the same time?
I think I agree with Buddy. It's a combination of all those factors. Millions of kids play baseball, and we only see a handful of these a year, and I have a very busy elbow practice. So it's a very rare condition, fortunately, but that's the best we know. That's the best we can tell patients is the cause of this.
Yeah, I agree with you all. It's sometimes difficult to pin down, and I think it's probably different for different people. But you certainly see these individuals in clinic quite often, and one of the big areas to discussion is, what is a trial of non-operative management? What does it look like? And truthfully, what does that patient look like? Because I often wonder if it's just the squeaky wheel, the return to clinic test that dictates when you operate. Maybe if we can start with you, Raffy, how long do you have them avoid inciting activity? Do you get routine follow-up imaging? And if so, is this advanced or are you just falling on plain film radiographs?
That's a great question. I think, Brian, it depends on the stability of the lesion and whether you're going to decide initially if you're going to treat this non-operatively or if it's something more advanced, like if there's a loose body or a more advanced stage that's going to need more aggressive surgical intervention and early on. So if you're just talking about the non-operative, it's a minimum of 3 months and usually even up to 6 months, which the patients and parents aren't happy to hear about. But I essentially tell them no throwing whatsoever. You can't even throw up your sock in the hamper, which the kids get happy to hear about. But they can play basketball. They can play any other sport for those 6 months. But I tell them no throwing. And then I get them back in 3 months, get a plain x-ray. They often want an MRI. The problem with it is it lags behind of the actual healing. So if I'm going to get another MRI, it's usually at 6 months when I've seen some progression in healing on plain radiographs.
Now, Buddy, I know you, like me, you see these baseball families that come in, and I sometimes think that there's a disconnect between expectations and what we've discussed with them. How do you manage those individuals that are somewhat impatient for getting a functional and symptomatic result?
Yeah, so for me, I like the MRI or MR arthrogram at the beginning, and I think most of the kids come in with that when you see them, but sometimes they haven't had one, so I'll do that first. I put them in a brace. I think the brace does a couple of things. The elbow has a natural valgus tilt. Most of the time, the OCD is in the capitellum, so you put them in a straight brace, and I try to keep it in a pain-free arc of motion. and let the motion come back as it wants. Now, with the brace on, I will tell them they can do whatever they want. They clearly can't pitch, but you can hit, run, do all these things with the brace on, and they can throw just a little bit if the brace is on. And pretty much for the first month or so, they're in it full time. So then the parents feel like you're treating them without taking them out of their sport, so to speak. But if their symptoms increase, then I do exactly what Raffy says. We shut them down. They can play other sports. But I think that's a good way to slow it down, and then try to temper the expectation that we need to give it some time to heal. This is not like a Tommy John surgery where, you're almost guaranteed to get back. This is one we want to let heal on its own, because if we start adding things, maybe the outcome's not as good as if it healed on its own. Now, if the MRI from the very beginning shows a disruption of the cartilage cap, and like Raffy said, there are loose bodies around, that may force your hand into a different outcome. But conservative management can work very well if you catch it at the right time and you refrain from stress to that capitellum.
Okay, now for the kid you're managing non-operative in that brace, is there any role for medications? Are you ever treating a kid with Forteo or vitamin D, or is there any adjuvants you can add there to try and help it heal more quickly, buddy?
Yep. So there's a couple of things. We put them on vitamin D and vitamin C. Sometimes we'll add some calcium. Most of the time we'll draw vitamin D level. I don't think nutrition has a huge role in the etiology. I actually don't think there's much to it at all, but I do think it can help with treating it. So I think if we're doing that, we're adding some therapy in to work on their shoulder, their core, their hips, those kind of things, take a little stress off the elbow, and then we'll do that. And then sometimes actually add in a stronger tissue healing supplement like Juven or Mend or one of those things that have some different compounds and peptides that help healing. We'll try to get them to do some of those things and see if we can't maximize the healing. I haven't used Forteo or one of the others. Once they move into the operative management, sometimes we'll do like a subchondroplasty type material into the capitellum to help. There's a lot of different ways to handle that, and I'm sure we'll talk about that after a while.
What about you, Raffy? Are you using any kind of supplement in this situation?
I think vitamin D supplementation is a good idea. I think amino acid supplementation, I recommend XR for these kids as well, can help. But I don't think there's any data. I haven't read any studies that shows that it can help healing. We're just throwing everything we can to get these kids back to playing quicker.
So, buddy, assuming we're heading down the route of surgical treatment then at this juncture in time, can you walk me through what the preoperative counseling looks like for this patient? What types of promises do you make for these individuals? What are the timelines you provide? Can you give a range of success? I'm just curious in how you couch this discussion so you can build that more realistic expectation.
Sure. I think that the first thing we try to do is talk to them about where their exact lesion is, because there's a huge difference between central lesions and peripheral lesions. And I think that's our the big decision making, because the peripheral ones, the return to sport is lower. It's what Larry and I a long time ago used to call shoulder lesions, and then Min Coker called them non-constrained or non-contained lesions. So the lateral wall lesions have a whole different outcome. And so if we have that, we have one discussion. The central lesions, I think, that are relatively contained do pretty well. And I'll usually tell them on the central ones that we're going to do whatever operation we're going to do, that I think in 6 weeks we'll be starting, if everything goes well and they get all their motion back, that we'll be starting a return to sport program for the most part. But I think the thing that I really talk to them about is stiffness. Arthrofibrosis and ankylosis is very common in OCD patients, especially our younger ones. And it's really critical, at least when I talk to them, about getting all their motion back. And we sort of harp on that over and over again, because when they say, well, when can I play baseball again? It'll be okay. Or softball again, or when can I go back to gymnastics? It's okay. The rest of your body has to be in perfect shape, but you have to have full motion of your elbow. So we need to start working on that right away, because once it gets stiff, then you're into a whole different problem set. And I think that's critical. On the lateral ones, it's a lot more pessimistic outcome. I just tell them, you've got ligaments that have to heal. You've got a wall that's got to regenerate. It can happen, but this one's going to have to depend on imaging before we can even think about a return to sport, and that could be as long as 6 months.
Well, I mean, that's we're really getting to the meat of it now, and this is exactly what I wanted to get to, which is who should be treated arthroscopically instead of with a graft. And you've talked to us a little bit about the lateral one and how that shoulder lesion, that uncontained lesion, has a worse prognosis. But I guess maybe I could push. Does that mean that patient should be treated primarily with a graft, or would you say that everyone should start with an arthroscopic surgery? What are your thoughts, Raffy?
I think it depends on the lesion and what classification system you use and what grade or what stage the lesion is at. I think, like Buddy said, the more medial lesions that are just lucent, if they're not healing with non-operative treatment, those are the ones that are going to do well. Especially if they're smaller lesions, younger patients, those are going to do well, which is drilling or microfracturing. Once you go to the lateral lesions, especially bigger lesions, including the lateral column, and older patients, those don't do as well with microfracture in my hands, and the literature shows that. So that's why I'm sure we'll get into this, but I've treated most of these with an osteochondral allograft. And as far as to answer your question, the return to sport, it's as early as 3 to 4 months they can start a throwing program, and they're fully released at 6 months to return back to play with the osteochondral allograft.
What do you think, Buddy? Do you agree with that overall kind of framework on age, size, location being what pushes you towards graft versus scope?
Yeah, I think so. I think that, like Raffy said, the central or the medial lesions on the capitellum tend to do really well. And, if you have someone that's involved in a really high-level contact sport, then an osteochondral graft's not a bad idea. I mean, I tend to do almost all of these arthroscopically no matter what. And I feel like I can use Scott Simon's portal and get a graft to key in for the most part. I don't have a problem opening them if I need to, but I'd really rather leave all the lateral ligaments intact as much as possible. The lateral wall lesions, though, if you start to lose bone, or if some of that has been debrided away, then you're really in a pickle, because now you have a bone defect that you have to fill, but you also have a ligament that's no longer attached. And that puts the player, the child, in a very difficult situation, because you're doing a major reconstructive surgery in someone that wants to get back to a high level of sport. So I think the lateral ones, I tend to be a little bit more aggressive surgically, even if it means I'll take an absorbable anchor and take out the permanent stitches and put PDS in and kind of key that into the upper part of the more proximal part of the capitellum, and use that to repair everything so that I don't have a permanent implant anywhere, and try to do it that way. And the other thing I've done is subchondroplasty to fill the defect. If the cartilage cap is pretty much intact, you can kind of fill it all up and it'll harden pretty quickly and give them good support. But I think having that lateral column intact, by whatever means you have to do it, is really critical for a good outcome.
I agree with you, buddy, and that's why I actually use the Takahara approach, which is a ligament sparing approach. It's like a transanconeus approach. So I leave the ligaments alone, and that's the beauty of the allograft, either autograft or allograft, is you can restore that lateral column, and you get pretty good containment of the graft, even if you're missing it from the condition.
Yeah, that's great nuanced feedback. I think what I've heard from you both is you're really focusing on that medial to lateral distribution and location. What about from A to P? Certainly specific sporting subsets like baseball and gymnastics, they present in widely different ways. And I found the gymnast to be the most difficult to access arthroscopically. Buddy, with your skill set, how do you manage this? What tips do you have for our listeners for being able to address this in arthroscopic or in a ligament sparing approach?
So I think the key, there's a couple of keys. One, I like to have my scope with a 70-degree scope in the posterolateral portal looking down the column, so I really get a good panoramic view of the capitellum. Gymnasts fall into two categories. One is the more central, kind of lateral type lesion. The other one that they'll get, because most of them have hyperextensibility, is a lesion on almost the true backside of the capitellum and high. The backside of the capitellum is easy to see, and you can access that out the back. When it's more distal and we're working on it, we use a distal soft spot portal, 7-degree scope above, and then your regular soft spot portal and a distal soft spot portal. And then you flex the elbow to about 100 degrees, and you have a really great view of the entirety of the capitellum. The way I position it, prone or lateral decubus, then the radial head is sitting kind of parallel to the floor, and you're looking at that joint really nicely. And it's pretty easy to gap it open a little bit so that you can access the entirety of the capitellum. I don't try to access it from anteriorly. I usually do that from the back because I think you have a better angle to work with, and you don't have to worry about the radial nerve.
Buddy, a quick question for you. When you do that, when you flex the elbow arthroscopically, that tightens up the anconeus in the capsule. Do you use any retractors to kind of open up that space and retract those structures out of the way for a better? Yeah, you do. Okay.
Thank you for bringing that up. I really do. I'll use two different ones. One is to pull the soft tissues back, and you can actually just use a probe or a little freer to do that. But the other thing you can do sometimes is bring in just a small trocar blunt and use it to open the joint up a little bit. So you just push upward, or you can use a thicker switching stick without causing any harm. So both of those open the joint up so you have easier access.
And that's a great tip.
Raffy, what about you? Lessons learned on how to approach this through a scope or an MIS approach?
Yeah, I just to be clear, I scope all of these at the same time as I'm doing the grafts because I can assess the joint better. I can see loose bodies in the gutters, anywhere essentially, and excise them arthroscopically. And then I just do that mini open transanconeus Takahara approach. And like Buddy said, the gymnasts are more posterior, so they're easier. The throwers are slightly more anterior, but I've been able to access every single picture by just hyperflexing the elbow and getting the radial head out of the way. Sometimes I have to use baby Homans to get into to place it to get the tissues out of the way, but I've been able to access every lesion of the patients in my series through that approach.
One of the things I think you said, Raffy, that is so important that I want to highlight is that you scoped every single one. For people listening, if you're going to do a graft, and I think grafts can work great, you should still do a scope because there can be osteophytes, there can be loose bodies, and you won't be able to see them through that Takahara approach.
You're right. And also,
can I ask,
yeah,
both of you have brought up what I think is an important point, which is the unstable lesion. Often there's a loose body. Buddy, you brought up some of those patients get stiff. Raffy, you brought up often I'm doing a debridement at the same time. There's clearly an inflammatory response that occurs here. I want to ask both of you, when does that happen? Is that immediately after it becomes unstable? Does it happen in certain patients? Is it predictable? Like, how do we know when we're going to see that? What are your thoughts, Raffy?
Yeah, I don't think everyone gets this. I think it probably depends on the stage. I would say about a third of my cases have synovitis when I scope them. And very few of them have a contracture. I mean, I can't recall off the top of my head in my series, but if they have a greater than 30-degree flexion contracture, I'm actually doing a capsule release. I'm doing something arthroscopically to get them to zero. If they only have like a 10 or 12-degree contracture, I don't release it because that's just more trauma, more bleeding, and more likely to get stiff post-operatively. So it's not a huge number that have a aggressive inflammatory reaction to this.
What about you, Buddy? I mean, clearly this is an intra-articular pathology. Do you think that happens when a loose body bangs around a lot, or do you think, how do you think that happens to these patients?
I think some people react poorly with more inflammation. Just because there's loose bodies floating around in these kids, it doesn't happen. But when they get that sort of inflammatory cartilage deterioration and they start to get that posterolateral plica gets very impinging on it, or Another common thing that happens is they start therapy and their arm is getting forced into motion when they've lost a little bit of motion, as Raffy said. When that happens and they're trying to force it, or you use, dynamic braces that kind of get motion or kind of force the motion, I think they get more inflamed and they actually get much worse. I think the best thing you can do when they've already started to lose motion is restrict them to the pain-free arc and let the inflammation settle down. I agree with Raffy 100%. I try really hard not to do a release on these kids. I think it creates more scar and more pain. That's usually a later operation for me, because I believe that if we just settle the elbow down, let the plica shrink down a little bit, that they'll get their motion back.
I think those are great words of wisdom. Can I follow up with you on one piece of that? So you mentioned earlier your portals and how you get great visualization, and certainly I think all seen your videos, and it's just beautiful. What are you doing about the plica? Like, when I've done these surgeries, often I feel like I end up taking the shaver and eating away the plica. Is there a consequence to that? Can I do that without worrying about it? Or is there a reason why I should try and avoid that?
So I think the plica of itself, the part that'll impinge between the radial head and the capitellum, that's one of the reasons they lose motion, and I think it actually makes the capitellar OCD a little bit worse. So I think it's sort of a vicious cycle. You get the OCD. We all see people that are kids that come in and you x-ray both elbows and it's on both sides, but only one is symptomatic. So I think what happens is they get a little bit of inflammation, the plica gets thicker, and it starts to impinge between the two. So I think taking out the plica is fine. I think you got to be really careful not to damage the lateral collateral, the radial ulnohumeral, or that posterior capsule has some ligamentous fibers in it, like Adam Watt has described. So that's a posterior lateral ligament. So you actually have your annular ligament and then 3 separate lateral stabilizing ligaments. You want to make sure you preserve those. But I will take out the plica. I think it's in the way, and I'll take it back kind of to the rim, just to the rim of the capsule, so that it can't impinge on in between the radial head and the capitellum.
That's great stuff. What about the bony bed? So if you have a stable lesion and you're approaching this either with retrograde drilling or transchondral drilling, do you have a preference one way or another? I also want to engage the topic of just biologics briefly. And then lastly, just as another teaser, when it is unstable, do you think we can get away with just a curettage of this? Is it mandated that we perform some form of fine wire fenestration or microfracture in a traditional context? Raffy, do you have thoughts on that?
There was 3 questions in one, Brian, but I think the way you approach this is you talk to the patient. I've had 30-year-olds who've had OCD their whole life, and they come to me and they have much bigger problems. They're obviously not going to pitch, and they're not going to perform, throw. They just want pain relief and to get their function back. So it just depends on what the patient wants. If they're low demand, you can get away with curettage and debridement and drilling microfracture. If they're high demand and their expectation is to go back to throwing, then my philosophy is I want to restore hyaline articular cartilage. And we know from the knee literature, if you have a big hole in your OCD and you remove the fragment and you drill the base of it, it's just not going to completely fill that hole up with fiber cartilage anyway. So it just doesn't work. So I start with just talking to the patient and their expectations and what they want to achieve before I kind of, decide on what I'm going to do.
I've often joked that, Raffy, every solution involves some element of an osteochondral graft and dermis, and you're standing on point there. So I appreciate you sticking to the script.
That's good.
Buddy, what about you? Any role for biologics in this as an adjunct or in isolation?
Yeah, I think there's a lot of different things you can do. Like I sort of alluded to earlier in the podcast, I have used subchondroplasty type materials and place them in when there's when you see the defect, it lights up on the MRI scan, you notice necrotic bone. It provides a solid bed and then it gradually, especially in these younger kids, will transition right into regular bone. So if you're thinking you have an avascular bed, it's sort of cystic, you're waiting for it to collapse, it can provide enough support that the rest of this can stay intact. And I think that's a really nice way to do it. We're not ready to look up our results on it because it's so particular on who you do it on. But if you pick the right spot, like everything, pick the right patient, it can be very helpful. Haven't done much with PRP or stem cells on these particular things. I usually do microfracture the bed. I think it helps regenerate if the lesion's not too big. I also agree with Raffy that once it gets, where it's a third of the capitellum, it makes more sense to put an osteochondral graft in, whether you do, a fresh graft from the knee. We had a little phase where I took actually a tip of the olecranon and just flipped it around and put it in there, and it worked pretty well. But your source can be different, and now we've done so much with these fresh osteochondral grafts that I think that's a very reasonable thing for the capitellum.
Buddy, can I follow you up with some questions on that? When you said the subchondroplasty, what exactly are you injecting into the lesion? Is it bone marrow concentrate? Is it a calcium phosphate or calcium sulfate? What are you actually injecting, and which lesions are you doing this for? Are you doing it for the ones that are kind of separated? There's a increased signal behind the lesion and the bed, and so it's not completely become a loose body, but they're separated. Are those the ones you're doing this for?
So there can't be any separation because you have to have a contained defect. And I use calcium phosphate because it hardens pretty quickly. And it's the kind where you sort of palpate the cartilage. The cartilage cap has to be intact. And then you can put this in, because if it starts to leak out, it's just going to go all around the joint. It's a complete waste of time. But you're trying to support that substrate and make it a little bit stronger so that the cartilage is less likely to collapse. And so if you, sort of similar thing, sometimes when you gap that lesion open, or if it's a flap and you see some bone there, then it's nice to put an absorbable anchor, preferably something with hydroxyapatite on it, and use PDS suture to sew it together. I think we get good healing with that, as opposed to a metal screw or some of the different transfixing pins you can get. I like to do it that way better. So sort of two different answers. One is if it's contained and the cap is intact, I think injecting calcium phosphate gives them a solid bed. They certainly become asymptomatic like right away, and they want to get back to sports, and so it's a much faster recovery because it's intact. The second one are the ones that are not stable, with gapping open a little bit and you can see it. I can't put that material in there just because it'll leak around the elbow. So in that case, I'm going to do something different, like a hydroxyapatite anchor with PDS sutures subbed in, so that I can repair the lesion without necessarily having to do an osteochondral graft.
So I just want to make sure I'm understanding correctly. It sounds like in your hands, there are some lesions that are maybe amenable to open reduction and internal fixation. Like there is a lesion where it's somewhere between unstable and stable, where you say, I can tack it down with some PDS and an anchor. And there's never one that you're fixing with a screw or a dart. Raffy, is that true for you? Like, I'm not sure I've ever seen one that was amenable to open reduction or fixation. And maybe I'm missing them. Which ones are you fixing, Raffy?
None. I haven't seen one that I can fix. Most of the time, the bone behind the fragment is kind of necrotic and dead, and you just can't stick cartilage back to bone. You got to have bone behind it, and it's always in at least the ones that I've seen. Buddy's experience may be different. The bone is just not good quality. So there are reports in the literature of fixation with a Herbert screw, for example, which is a headless compression metal screw, but you always have to go back and take it out. So I personally have no experience with that.
It's very interesting. Bernie Morey, when I was a resident, came and told us the same thing. He said, oh, you can fix them with PDS and it works, but I've never seen any papers on it. And then I went to fellowship and I asked Ken Yamaguchi, have you ever fixed one? He said, I've never seen one that could be fixed. Then I asked Mark Cohen the same thing. He said, I've never seen one fixed. So I still don't understand. I'm not sure I've ever seen one fixed. So, buddy, you got to tell me, what's the one that I can fix? Like, I can't find that one. I'm sure that it exists. I'm just not seeing it.
So it's one of those things. I don't know how common it is. I do know that I've tried it and it's been successful. And there's a lot of different ways to do a PDS technique. You can do it actually drilling all the way through the bone. I do think you have to have a little bit of bone on the lesion. And one of the things is other people say, well, maybe the whole thing's popped off and it's floating around inside the joint. That's not one that I can fix. I think that bone, I agree with Raffy, that bone is just not very good, and trying to put it back is not going to work. If you have a huge capillary defect behind it, that's not going to work. But the ones that are, I guess, in the process of decaying a little bit and they flap open when you get in there, I think there's usually enough bone. The bone's not too bad. You kind of gap it open, freshen the bed a little bit, and then you, like I said, I use an anchor, but you can do PDS. And then the hardest part, guys, if you do this, is to pass the stitches kind of through and around the fragment arthroscopically. And I actually pass them with the spinal needle. So I will put the spinal needle through the piece, shuttle a PDS through it, a free PDS, and use that PDS to pull the PDS and the anchor through the fragment where I want it to be. And you go four corners and you pull it back, and it ties down very nicely. I think you just got to be open to it. There's some that you can do it on, especially on the younger kids, that seem to do pretty well. The older ones, I think Raffy alluded to this early in the podcast, the older ones are a different ballgame. They're just looking for pain relief, and that's a much more degenerative situation in addition to the fragments. And so that I don't think you'll see one that you can fix there. I don't want to do metal screws. I think metal screws, you have to take them out, and usually, in my experience, the bone's not thick enough to tolerate a screw. And then the darts are mostly are the ones that I've mostly had to take out, and they've really destroyed that radiocapitellar joint. So not a fan of either one of those.
Yeah, buddy, I think you're one of the only few people who can fix it arthroscopically through the lesion the way you're described. I can't even imagine myself trying to do that.
You would do great. I can show you one time. You're a better surgeon than I am. All three of you
No
are.
way.
You could certainly make it happen in a minute.
You're too kind.
So, buddy, God forbid that PDS fails. Let's engage a little bit on the topic of autograft versus allograft. We've certainly seen the benefits of allograft across a wide different sources. You know, some have used the lateral femoral condyle, some have gone with matched capitellum. What is your preferred graft? Are you going to the knee? Is that something you're routinely taking fresh grafts? Walk us through your thought process.
Okay, so I think younger patients that I really have to have a graft, especially if it's a lateral wall, I really like going to their own knee and taking it. That being said, I've had a much lower tolerance for using osteochondral grafts, thanks to you guys like you all that have done the work, and Raffy's work especially, because it's a lot easier on the patient to not make an incision on the knee and put it in there. And it sounds funny, but Matt Provencher's work in the shoulder, I mean, when I was growing up in orthopedics, we were taught you could never do an allograft of any kind in the shoulder. It would just dissolve. And so I think we've gotten better with sampling, with how we handle the tissues. So I have much less of a problem putting an allograft osteochondral piece in there. I think it's, again, it's much easier on the patient. So depending on what's going on, I'll have a discussion with the patient and their family and let mom and dad kind of decide. And I really try to be as unbiased as possible, because I think thanks to Raffy and folks like him, we know that this can work very well in the elbow. By the same time, if they ask me point blank, do I think one is a little bit better than the other? I would say, taking your own tissue from your knee is better, but your knee's going to hurt some, and there's always potential for problems there.
Yeah, that's been my experience as well. It's a little bit of a bait and switch, where the autograft oats definitely has stronger biologic potential, but then they come back complaining about their distant, uninvolved joint.
Right.
And some of the foot and ankle literature suggests that this may be up to 17, 18%. Raffy, what about you? What's your graft of choice? Are you going to the lateral femoral condyle? And if so, where are you harvesting that from? Can you walk us through what enhances success?
Yeah, I think either autograft or allograft is a way better choice than microfracture, lavage, drilling, just arthroscopic only treatment, because both of those restore hyaline articular cartilage that's going to withstand the loads you're going to put back on the joint when you're throwing again. So either one is great. The reason I choose not to do autograft is what Buddy alluded to, is the donor side morbidity, and anywhere from 8 to 10% has been reported in the literature. And I just can't bring myself to cut open a good looking knee that's perfect, pristine, that has no problems in a kid, and then have a risk that it could potentially have pain in it in the future. And there's a lot of surgeons who do harvest from the knee, and they swear there's no donor side morbidity, but the literature says otherwise. And I do, as you said, Brian, I do a lot of osteochondral allografts in the knee, and I've been using it for almost 2 decades, and I feel very comfortable doing it. So that was a very easy transition for me to just use allograft. So I use exclusively osteochondral allograft, and I want to stress that this is fresh osteochondral allograft. And I think what Buddy was talking about in the past, we didn't have the ability to have fresh osteochondral allografts. They were all cryo or frozen, and frozen grafts are different than fresh grafts. They're a different ball game. I was able to obtain MRIs on about half of my patients in my series that had fresh osteochondral allografts. Every single one of them, the graft was incorporated. There was no reaction, no edema. And part of the reason, I think, these are smaller grafts, so you're able to lavage the bone marrow elements out very well, and you reduce the risk of getting any kind of reaction towards it.
Raffy, I want to follow up with you about this a little bit, because one of the things that I think is interesting, the capitellum has its own particular curvature, which is that it's a smaller radius, tighter curvature than the femoral condyle. So, is there a critical lesion size at which you would say, if you're going to get a graft, that has to be capitellar graft, so you get that curvature, or are there some lesions where you say it's small enough I could use one of those off-the-shelf femoral plugs that are more quickly available? What are your thoughts? Are you a capitellum or die guy, or are there some small lesions where you would say maybe it's okay to use the femur for this?
No, I think the smaller the plug you're using, the less the radius of curvature matters. So if you're replacing a 25 or a 30 millimeter lesion with that big of a plug, then you want to match the curvature. If it's a 6 or 8 millimeter, the radius of curvature doesn't matter as much. And most of these are smaller lesions. My average diameter was 10 millimeters that I use. So, and surprisingly, that part of the capitellum is flatter than you would think. It's not perfectly rounded, and it actually comes really well from the lateral flare of the trochlea, where it's much flatter in the lateral hemicondyle. And also, to clarify, Peter, I use the lateral hemicondyle of the knee for the majority of the time from a donor. And that's where I harvest my plugs, from that flat surface. I don't get it from the back of the posterior condyle, which has a much rounded radius of curvature. I hope that answers your question.
Yeah, that's great. That's exactly what I was hoping to get. Buddy, what are your thoughts on that? If you're going allograft, what is your graft of choice?
Well, I really prefer capitellum. I agree with Raffy. Small lesions, it probably doesn't matter, and so it's almost whatever I can get would be fine. But if it's a bigger one, I mean, if you're talking, 15 millimeters or majority of the capitellar surface, then I'd rather have a capitellum.
Yeah, and I would too. If I had it my way, I would too. The problem is there aren't that many of them around.
Right.
The tissue banks don't have elbows laying around, and part of it is because upper extremity grafts have a higher contamination rate. So a lot of times they won't even harvest anything from the upper extremity, but they have a lot of lower extremity. There's a lot of lateral condyles that don't get placed. They don't get used from donors. These are, this is a gift of life, essentially, that get thrown away. So I tell the tissue banks, give me the smallest lateral femoral condyle that you're not going to place with any patient in the next 2 weeks. I'll take it, and I'm able to use it instead of having it go to waste, essentially. But if I had it my way, of course, I would do the capitellum.
I wanted to follow up with both of you about this, because I think this particular issue, I think, is an interesting one. It's interesting because I agree with you, Buddy, that Like, I think there is a difference in radius of curvature. I worry if I'm putting a flatter graft, does that reproduce that same curve? Is like when the patient bends and extends, is it more likely they get arthritis in the long run? This is the thing I really want to ask both of you, though. If I do a chondroplasty or a microfracture and the patient gets fibrocartilage, is it flat or is it curved? What do you think, Raffy? What has been your experience?
Again, I don't have experience in the elbow. It just, my best medical guess is that it will conform with the surface of on the other side of the joint. So essentially, the concavity of the radial head will help shave the fibrocartilage that's going to fill the defect. It's just a pure medical conjecture. I'm not sure.
So actually,
what do you
Raffy,
think?
I think you're right, because I've looked in on some for different reasons, and I think the fact that the radial head is a little saucer shape makes the capitellar area contour back so it matches. So the ones we've been able to look back at a little bit on for a variety of reasons, it's always contoured really nicely. So I think that's what happens.
Now we've danced around the topic of treatments and rehab and some of the surgical pearls. What about timeline for return to pre-injury activity? And specifically, I want you to engage those two subsets we talked about. The throwing or overhead athlete, where there's definitely a unique valgus stress that's loaded there. But then additionally, the gymnast. Can you walk us through what those individual sports subsets look like for timeline to return to play? Buddy, maybe we start with you.
Okay, so central lesions on either group, usually 6 weeks, they're feeling pretty good. As soon as they get their motion back, at that point, you've microfractured, you haven't put a graft in. I think they tend to progress really nicely. We talked earlier about I used a brace. So for my baseball players, usually somewhere around that time frame, if they're a little slower, not getting their motion back, maybe 3 months, and then we'll start the return to throw. On the gymnast, it's a little bit different because they really need to be healing and they're going to do impact. So then you have to figure out what you want to let them do in terms of the elbow as they get back, because they have to pass a whole plyometric program because they're going to be impacting if they're vaulting, if they're doing their floor exercise. So I get them back doing non-weight bearing on the arm exercises first. And as soon as once they can get to where they can do that, then we'll start gradually moving into an impact type sport. So my gymnast may take 6 months, some even up to 9 months, but we're sort of shooting to begin that return to gymnastics around 4 months.
And Rafi, does postoperative imaging play into your decision making as well, and any difference in those timelines?
No, I don't use post-op imaging to guide whether they're going to return to sport. I don't treat the gymnasts and the baseball players any different. Like I said earlier, usually at 3 to 4 months they can do a throwing program and they're back to full throwing, full activities at 6 months for both types of sports. I usually got the MRI there's asymptomatic. I got the MRI to just assess the graft healing incorporation because I was still following these patients for my study. But I don't use it to guide my treatment of when they can return to sport.
I want to thank both of you for coming on. I mean, this was just a real tour de force. We heard a ton about different modalities of treatment, evaluation. Guys, this is a hard thing to get good knowledge on, and I think listeners are going to really get a lot out of all the pearls that you provided for us. So thank you so much for spending the time. We really appreciate it.
Absolutely. It's completely an honor to be a part of it. Thank you guys so much.
Thank you, guys. Thank you, Peter and Brian, and also Rachel, for doing such a great job with the podcast. I'm an avid listener. I listen to it every time it comes out. So it's an honor to be on here with you guys. Thanks for having me.
You all are definitely a brain trust in this topic, and Peter and I have a lot of enthusiasm for it. So thank you for sharing your expertise and words of wisdom. For our listeners, that's about all the time we have for this podcast. Thanks so much to our guests. For all our shoulder and elbow listeners out there, don't forget to subscribe. And for Peter Chalmers, I'm Brian Waterman. We'll see you next time. Thanks.